get started in the interest of time, I wanted to, so before we get started, just raise your hands in this room if your life has been personally impacted by suicide. So much. That is way too many. Way too many. So this is a unique topic. This isn't a fun, this isn't a feel-good topic. It is one that is critical to all of us. It is not something about a patient you might see occasionally or a learner you might encounter once a year. This is about our colleagues, our peers, our friends, ourselves. This is about people we interact with every single day. So important. So please, I think it was just about a year ago that we started thinking about we need to have another session on physician suicide. And so naturally I thought, who's going to be great at doing this? I immediately thought, well, maybe the chair of psychiatry will have some recommendations for who might be good about talking about this. So I emailed Bob, and as is typical with any time I've ever emailed him, I got a response within an hour. And he said, you know what, Sherry? This is a subject that is near and dear to my heart. I would love to give this talk. I said, are you sure this is going to be 2 different sessions? You got to repeat it. Yes, absolutely. Important topic. So here he is to give this talk today. I also wanted to mention, this is a resource that we have. These you can sell on eBay probably soon because these are the last printed copies. They have, if you take a piece of paper, you can access them online also. But these are the last printed copies. They're created by the Campus Suicide Prevention Center of Virginia. They are, the information is not outdated. I've had Dr. Trustman review them also to make sure that he felt good about it, and some other folks. But if you want a hard copy, feel free to take them, or if you feel more comfortable with online version, take a piece of paper. But please join me in welcoming Dr. Bob Trustman.
Thanks so much, everybody. While this is structured as a presentation, please do feel free, if you've got questions or comments, just interrupt in the flow of this. I think it's important that this is something that if there are concerns, if there are questions that come up, that we can talk about them rather than just blast through a series of slides. In terms of disclosures, I do have to acknowledge I am biased. I have a strong bias of keeping people alive. And so that is something that will run through the course of this talk. Let me start off with a case example. And this was published elsewhere and fairly generally. Dr. Michael Weinstein, a trauma surgeon who was practicing at Jefferson Health in Philadelphia, received treatment for depression throughout his 2-decade-long career. He never discussed it with colleagues. He was afraid that they would be perceiving him as weak. In 2016, he fell into a deep depression. It was bad enough that he was contemplating killing himself. His wife forced him to see his primary care doc, who in turn convinced him to take a leave from work and admit himself into a psychiatric facility for treatment. He had said that I needed somebody to tell me to stop working. It was the fear of telling people I couldn't do this anymore. It felt like it was a sign of weakness or my own failing. When he did return to work, he decided he'd be honest with his colleagues before rumors started to swirl. After years of hiding his depression, his colleagues embraced his story, talking about their own experiences and acknowledging that they knew others who suffered from mental illness or who had committed suicide. So, while there's a series of things I'd like to cover today, again, as issues or concerns come up, please feel free to address them and let's discuss them. The work we do in medicine, and as I say this, let me just add the caveat. Most of this will focus on physicians and physician learners. The same really applies to all of us. whether it's social work, nursing, psychology, anybody who touches the life of someone who is suffering and for whom we're trying to provide care. We all grapple with these same issues and concerns. But for today, I'm focusing on the training and development and practice of life as a physician. We make decisions and we perform procedures at virtually every interaction we have with our patients. We can make mistakes. Even when we do everything right, things go wrong. Our patients may not improve. They may suffer negative consequences of our interventions, our decisions, or because of the ongoing evolution of their illness, they may get worse. They may die on the table if there's a procedure. That takes a toll on us. We work hard to create appropriate boundaries and barriers so that we can tolerate the emotional distress of what we do. But that doesn't mean we're machines. We are people. We are connected to the work we do and the people we care for. And we each respond in different ways. But as a profession, the consequences are really clear. The risk of physician suicide is high, higher than in most any other profession. One of us dies every day in this country. By the most conservative estimates, one physician takes her or his life every day. In the general population, male suicide is about 4 times more common than female suicide, in part because of the method that's used. Men tend to use more lethal approaches that are irreversible, guns. Women tend to die by overdose. But the suicide rate among physicians is arguably gender neutral. Most of the data suggests that women physicians kill themselves at the same rate as do male physicians. And what contributes to it? Well, it's both burnout and stress and depression. This was a survey done by Medscape where about 15,000 physicians responded from around the country in all different disciplines, specialties. The burnout rate for practicing physicians, on average, is 42%. 42% of us are tired. In addition, about 12% say they've got symptoms of depression, and about 3% acknowledge being clinically depressed in the self-report online survey. And this varies by specialty, going from around 20% of OBGYN physicians who acknowledge both feeling depressed and burned out, all the way down to the rosy numbers in psychiatry, where only 8% of my colleagues acknowledge feeling depressed and burned out. But these are tragically high in a profession where we are dedicated to caring for people and reducing suffering. What contributes to physician burnout? Bureaucracy, dealing with charts, paperwork, all the bureaucratic tasks are acknowledged by 56% of people as being the single biggest contributing factor. Spending too many hours at work, clearly, an occupational hazard for us all. A lack of perceived respect from colleagues and administrators. Over a quarter of us experience that. Electronic health records. These things were never designed to make our lives easier. They were designed at this stage to improve quality of care and documentation and accuracy, which in theory improves the care we provide to our patients. Maybe our children who become physicians may experience EHRs that actually make our lives easier, but it ain't gonna happen quickly, but at least not from my experience. Insufficient compensation, lack of control, and certainly autonomy in that sense, as we are going through year after year of disruption in regulation, in the sophistication of what we do. And so it's a very challenging environment. So each and every one of these factors can contribute in different ways. Bottom line, there is a lot that can make our lives difficult and frustrating and can essentially rip the joy out of the work that we are dedicated to. So let's talk briefly about the overall epidemiology of suicide in our country. It's the 10th leading cause of death in the United States overall, contributing to about 45,000 known deaths by suicide. There are so many additional deaths that are likely caused by suicide, but not ascribed to it. Single car accidents, for example, are all too often associated with suicide, but may not be documented as such. For every completed suicide, every study has suggested that at a minimum, there are 25 attempts that may go unreported. So the population of people at risk is far, far greater than those who have completed suicide. And forgive me for getting on a soapbox, but let me be a bit pedantic for a moment. I've heard oftentimes and in many contexts, people describe about a successful suicide. Sorry, as a physician, I just don't believe that there's ever such a thing as a successful suicide. There are completed suicides, yes, but I would encourage all of us not to use the word successful in combination with the word suicide. The costs, just the financial costs to our nation, are at least $69 billion annually. And around 13.4 people per 100,000 die each year by suicide. 123 of us nationally die every day. Firearms account for over half, about 51% of these deaths. And so while middle-aged individuals are at highest risk, there are also bimodal increases occurring in the elderly, over 75, and young people. Adolescent suicide risk is significantly increasing over the last 5 or 6 years. So the increase overall over the last 5 years is significant. And adjusting for age, the annual suicide rate over the last 16 years, from 99 to 2014, increased by 24%. And it continues. So we are facing real challenges. A lot of it may be associated with the economic downturn. Many people still are grappling with the consequences of the Great Recession of 2008. And there are so many issues that have spun off from that. Certainly, as people have lost their jobs, they may have lost their insurance, their access to appropriate medication, on and on. The suffering can really accumulate. But what about physicians in particular, not just those in the community? Well, not that it should be something new to anyone in this room involved in healthcare, but stress accelerates when you get to med school. First, it's not like people who go to med school have had lives where they've been laid back, relaxed, stress-free, right? Realistically, you've got to be in the top 5% of your class. Many people who go to med school were salutatorians or valedictorians just to get there. Then when you get there, everybody else is already a high achiever, used to being at the top of their class. And so they come with an attitude of competitiveness. They come willing to and expecting to work long hours. And they're starting to really experience sleep deprivation and stress and frustration that they may no longer be in the top 5% of the class. They expected to be AOA, and guess what? They're just at the 40th percentile of their class. So this can certainly contribute to consequences associated with stress, substance abuse, which is another significant risk for suicide. Physicians as a group have a significantly lower risk, a mortality risk, from cancer and heart disease than the overall population. In general, we're a healthier population, but we have a significantly elevated risk of dying from suicide. After accidents, suicide is the most common cause of death among med students. Accidents, number one, keep in mind most med students are still not yet 26. They still tend to believe they're immortal. They still tend to drive too fast or take risks. And so there is a significant risk for accidents in a young adult population. But among those that are really experiencing a lot of distress, what are the common associated diagnoses? Certainly mood disorders, alcoholism, and substance misuse. So the factors that contribute to elevated suicidality, burnout, as we've described. And burnout doesn't just come after 30 years in private practice and then you've got to deal with an EHR. It also happens when you're in med school or residency and you're beginning to feel a little disillusioned. It isn't exactly what you thought it was going to be. There's a lot more business and electronic health records and a lot of administrative stuff than you ever expected there would be or should be. But all that said, burnout does increase with years in practice and by specialty. And specialty ranges from 23% up to 50%. The slide I showed earlier focused on the co-occurrence of depression with burnout. But some of our specialties have a burnout rate of 50%. The average of 42 is just that, an average. Now, why is it, do you think, that people might not be willing to seek help? There are problems. We encourage our patients all the time to come see us for treatment. We don't think there should be a problem, that people should come and talk to us about, their aches, their pains, their distress. Stigma is a huge issue. Stigma broadly about mental illness, about substance misuse. Clearly, the fear of potential negative impact on your training and career is an enormous issue, and we'll drill down into that in just a minute. But also, the pervasive belief that I just need to be tough. I need to be able to deal with this. If I'm going to be a doctor, or I am a doctor, this comes with the terrain. I need to suck it up and keep going. And the more we believe that we are more than human, the more we expose ourselves to these conditions and these problems. Because we are, at base, humans. And we suffer the same way our patients do. Now let's focus for a moment on med students. As I mentioned, applicants for med students or for residencies are extremely unlikely to report a history of depression during highly competitive selection interviews. They're going to minimize that if they can get away with it. The prevalence of depression in these populations, particularly in med student and postgraduate trainees, is universally not really well known. The estimates that we've been able to develop are at least 15% and as high as 30%, as in non-trivial. In one study, 9.4% of fourth-year med students and interns reported having suicidal thoughts within the last 2 weeks. Another study found that about 80% of fourth-year med students and interns reported symptoms consistent with a mild to moderate depression. 80%. Learners, however, often delay or don't seek treatment because they fear being perceived as weak or less capable than their peers. Because if you don't talk about something, then you think everyone else is great. You're the only one dealing with this. There are always, no matter how we work at working to improve our clear status and the clinical learning environment, there can be harassment and belittlement, big and little, from our professors, higher level trainees, as well as the nursing staff, that can contribute to mental distress of students and contribute to the development of depression in some. But even positive workplace changes, you did great in your last rotation, you're now starting a new rotation. You just got accepted to the residency of your choice. All of those are really stressful because each time you go into a new environment, you've got to prove yourself all over again. You've got to learn not just where the bathroom is, but when you think you're allowed to go to the bathroom without any repercussions. Suicide in medical trainees, in terms of the numbers, is most likely to occur at just prior to beginning a clinical rotation. The anxieties are high, or prior to or at the beginning of residency. So these are high-risk transition periods. As people progress into residency, one report found that depression is not uncommon even among pediatric residents. Up to 20% of pediatric residents reported in 3 programs about 20% of feeling depressed. And while there's no absolute, in general, we tend to think of residencies in pediatrics as perhaps warmer and fuzzier than certain other ones. So if this is as good as it gets, think about how difficult it may be in other environments. So these studies have found residents who experience depression may be as much as 6 times more likely than those that are not acknowledging symptoms of depression to make clinically meaningful mistakes, right? You're not concentrating, you're tired, you're having a hard time paying attention. It's easy to make medication errors or other kinds of things, other kinds of errors that will have an impact on people's lives. So what are the things that can contribute during the clinical training process to the tendency towards depressive symptoms? The long hours. Even now, as we try to restrict in training people to no more than 80 hours, we've come a long way in this, maybe arguably even too far, in reducing continuity of care issues and exposure to appropriate range of clinical experiences. 80 hours a week to stay on point, sharp, and making decisions that could have life and death issues, that's a lot of time. Having to make these difficult decisions while being at risk for errors as you're still learning, as an intern, as a junior resident, that plays on people's minds. In many contexts, even though there's supposed to be more senior people available, there can be subtle or not so subtle pressures to expect people this stage in your career, you should make that decision for yourself. Go ahead, make it yourself. And not feeling like you have the experience or sophistication to do so, nevertheless trying to. We deal with death and dying. That's a part of what we do. That doesn't mean it's easy, and it doesn't mean it's ever easier. Heaven help us when we don't care anymore, right? That's what burnout leads to. When we no longer care, when there's compassion fatigue. And at that point, we're far down the line of no longer caring about what we do. In training, there are frequent shifts in our workplace. Just when you settle in a rotation and you know what's happening, boom, you're in another environment. You were in an ICU, okay. Now you're in a step-down unit. You were on an inpatient rotation, now you're in outpatient rotation. So there are so many different changes of context, each of which is stressful. And couple this with the fact that for most learners, they're no longer near their families. They're no longer physically near their emotional support networks. And, yes, FaceTime and messaging and the other connectedness may help, but it doesn't ever substitute for a hug. It just doesn't. What about us in practice? A survey of American surgeons revealed that 1 in 16 had experienced suicidal ideation in the past 12 months. 1 in 16 had suicidal thoughts in the last year. And only a quarter of them had sought any type of help. A recent survey found that nearly 40% of practicing physicians would be reluctant to seek treatment of their distress out of concerns that people will think less of them, that it might be reportable, it might have an impact on their careers. 60% who actively had suicidal ideation reflected later that they did not seek care because it could affect their licensure. And sadly, that concern is real. It can. Dr. Pamela Weibel, as she was training, lost someone close to her and became fascinated with the whole issue of suicide in physicians and made it as part of her career. She was dedicated to doing and finding episodes and finding cases of physicians who committed suicide and trying to understand the context in which it was happened by digging into the records. She was able to study 547 cases of completed suicide in physicians. What did she find? And I don't know that this will surprise anyone on reflection. Again, just like the community, women physicians tend to die by overdose, men by firearms. Male anesthesiologists are at highest risk. They have the easiest access to drugs, and it is, 95% of the time, it's boring. And then 5%, it's life or death within seconds of decision making. And so it's a very, very stressful job that we choose as anesthesiologists. Here's an interesting thing to ponder. Even physicians who seem to be happy, they're going around smiling, they're the ones who crack jokes, they are engaged, they're planning. They die by suicide too. Think about who you are as an individual and the skills you have, and how good we all are at putting on a face when we deal with our patients. No matter how much stress we're experiencing at home, our second grader is having a hard time with friends. We're not sure where we're going to be able to afford, to pay for college for one of our kids next year. Whatever the stress is, when we sit down with a patient, we put on a whole new face. That's what we do. Same thing, all too often with our colleagues, where we work really hard to try to put on a good face, and some of us are really good at it. So we're all at risk, and just because you see colleagues who appear to be happy doesn't actually mean that there isn't something underlying that smile. We all have personal problems, like everyone else, and we frequently don't have the time to deal with it. Our own personal pains, our own frustrations, and if we don't deal with it, we live with it, and it festers. Patient deaths hurt us a lot. So even when there's no medical error and our patients die, doctors may never forgive themselves for losing a patient. And it's easy enough to think, and reflect, for how many people here have lost a patient to death? Not to suicide, just to death, right? And when you do, if you've worked with that person over months and years, or you've worked intimately with them on an inpatient unit in an ICU, or you've followed them, and you lose them, that hurts. And so For some of us, particularly if we second guess ourselves, if I hadn't chosen that presser, if I had made this decision to encourage them for surgery 2 months earlier, would they still be alive? And so these are the kinds of challenges we live with. Additionally, academic distress kills medical students' dreams, right? Failing board exams, not passing the different step exams, you're toast. If you're unmatched into your own specialty of choice, that has led to suicides a lot. That's not just one example. There were many. And we can't easily get confidential mental health treatment. It can be difficult, certainly in a rural area like ours, where everyone knows everybody. You discharge a patient from here, and you're going to see them in Kroger's 2 days later. So we all know each other. And it makes it much more difficult to get confidential care. And additionally, we tend to have difficulty treating other physicians. There's the VIP syndrome. In general, physicians are at risk of getting a lower quality of care because we don't want to make the intrusive decisions. We don't want to put them through the discomfort that we might put another person through who we didn't have that same kind of emotional connection to, since they're part of the clan, right? They're part of the profession. Physician health programs, certainly those run through medical boards, can inadvertently increase suicide risk. It varies by state. Each one is very different in the laws they set. But once you're enrolled in a physician health plan, you've lost autonomy. If you don't go through with what they require of you because you were hospitalized for a substance abuse problem or for a mental illness, and if you don't follow through the protocol that they require of you, then you don't get to practice medicine. So these are some of the real challenges that may, in some settings, be very fair, others may be draconian or inappropriate. So these are real issues that as a field we're still struggling with. And then all of our cultural taboos reinforce this level of secrecy. And so these are the challenges that undergird a lot of these issues. Let me pause a moment to see questions, comments, anything you disagree with anything that I've reported so far?
No,
Neil.
don't disagree. I was going to say, it's not like anyone requires any validation of what Dr. Crescent is saying. But unfortunately, spot on. I mean, we've had 3 anesthesiologists here in the Valley within the last 10 years. So this really is, and gosh, I wish I could say we were halfway decent at even suspecting this, but we never do.
Yeah. And so some of this will require a culture change. And towards the end of this presentation, that's what we'll focus on. One of the stigma issues associated with mental illness is the perception and the belief that it's a moral weakness. Addiction or mental illness is a moral flaw, a failing. And as long as we believe that, we're going to treat it like that. It is incumbent upon us to think through and understand the fact that these are disorders of brain functioning. I would not be a modern psychiatrist unless I showed a pretty picture of a brain. So here's at least one pretty picture of a brain, emphasizing some of the areas involved in mood disorder, abnormalities, documented every which way you can imagine, whether through PET binding studies, fMRI, structural CT, where there are abnormalities that are found in significant mood disorders, whether it is through the traditional limbic system and the striatum, as well as cognitive areas in the dorsolateral prefrontal cortex and other areas like the anterior cingulate. There are measurable disturbances that we can repeatedly find. Additionally, we find in areas of catecholamine dysfunction, whether it's dopaminergic, noradrenergic, serotonergic dysfunction, as it relates to, in a mood disorder, or a stress-related disorder, there are increased negative emotional states. Depressed mood, feelings of disgust at oneself or guilt, hostility, irritability, loneliness. On the other side, there are also reduced good emotional feelings. There is a loss of joy. There is a loss of energy and enthusiasm and interest, decreased concentration, decreased self-confidence. So both, the negative is exacerbated, the positive is reduced by these abnormalities. And again, we can measure abnormalities in each of these neurotransmitter systems in mood disorders. And this has been documented for 30 years. And it's not just in the catecholamines. It occurs in the glucocorticoid system, and BDNF, as we look at all of the changes in the inflammatory system as well. So there are a cascade of events that occur in stress-related disorders, in addictions, and in mood disorders, unambiguously, that we find over and over again. And so we see measurable abnormalities in significant depression or chronic stress disorders in all of these areas. So in this context, I just wanted to flash this up there. The slides are available. It's available online as well. But it's important for people to recognize that if we're going to change the culture, we're going to change stigma. We have to reinforce the fact that these are biologically based abnormalities, just as there would be. You know, we don't see a failure in hepatic functioning to any significant degree until 90% of the liver is sclerotic, right? Until we're just a step away from cirrhosis. The liver is able to compensate until it no longer can. As people, the brain works to function in a similar fashion until it can no longer compensate, but it tries to compensate. It's not just the regulatory mechanisms for homeostasis of blood pressure in the brain that's autoregulatory. All of these mechanisms are autoregulatory until they're not. And that's what happens under chronic stress or addiction or an acute mental illness. This doesn't only happen in depression or addiction. There have been studies done repeatedly now around the world focusing on the changes that occur in an individual who is contemplating suicide. Measurable changes in people who have attempted suicide, and we have studied it or studied pre-morbid, as they're thinking about it but have not yet attempted it, or particularly the work that's been done by John Mann up at Columbia over the last 30 years in the post-mortem brain, where he's been able to harvest brains of people who have completed suicide and look at the structural and neurophysiologic changes that have occurred. They are significant, repeatable, measurable. So the suicidal brain is a real thing. Mood disorders come in lots of different shapes, flavors, and categories. Lots and lots of different depressive disorders. You know, whether it's disruptive mood dysregulation disorder in adolescence, major depression, persistent low-grade depressions or dysthymia, premenstrual dysphoric disorder, on and on and on. Bipolar disorders come in lots of different variants. All of them come with different specifiers for the level of anxiety or other associated problems, psychosis, and so forth. The anxiety disorders that are associated with stress, post-traumatic stress disorder, acute stress disorders, different adjustment disorders. All of these arguably have the same underlying neuropathophysiology. They do. We have not yet found the underlying trigger mechanisms, but we can see the cascade of consequential events, which is partly why there's such a forest here of different diagnoses. In 10 years, I expect that this forest will be whittled down to a few trees as we understand the underlying pathology. We're getting there. All we see now is the consequences, the cascades, the risk pattern of both genomic and epigenetic expression, that we are piecing this together. Suffice it to say that nevertheless, we can make these diagnoses, we can use these categorical diagnoses, and whatever the diagnosis, these are treatable illnesses, and we can help people get better. A lot of the time there's a challenge and a concern. What's the difference between just stress and a formal mood disorder? Bottom line is not a lot. When you talk about stress, I think virtually everybody here may have seen something like this in your introductory course to psychology back in college. And it applies to anxiety and it applies to stress. The x-axis is either anxiety or stress. The y-axis is your function level. Inadequate anxiety, inadequate stress, you're lying there, you're smiling, you're happy, but you're not productive. And if you're called upon to make a decision, you probably won't make a really good one. As the anxiety and the stress level increases, we get to a point where we have an optimum balance. We're stimulated, we're excited, we're engaged. The sense of a peak experience, when each of us doing whatever we love the most, we're fully, if you will, in the moment, that is where we make our best decisions and are most productive. If the stress increases, if the anxiety level increases, it goes downhill from there. Each one of us has a different threshold and a different optimal level. We do. Some of us work hard to avoid those stressors, so we plan, we do in advance, we get everything done. Others of us are not productive unless it's all due in an hour, and we're scrambling, and the adrenaline is rushing. There's a real threat. If we don't do it, there'll be all hell breaking loose. So we do a good job for some of us. Everyone is different, but everyone has a point where they enter that red zone on the bad side. Everyone has a point where the stress is simply too much and you just don't perform. And we can look at different models of this, but each of us has our own internal resources, our own internal strengths that we bring to the game, a level of resilience that we each have, whether we're optimistic or pessimistic and so forth. Then there are all of the stressors that we experience in life. As always, the expression goes, life happens. It does, and we have to deal with that. The demands, the tension, the worries. But stress is very different than distress. How we experience those stressors, how we perceive them and interpret them, and how we cope with them. And depending upon that, leads to potentially chronic distress, which can then become formal, consistent, and persistent anxiety or depressive disorders. Does that make sense logically? And so there are many different forms of stress continuum models, some of them propagated 100 years ago. Does the name Hans Selye ring a bell for anybody? So, in the original stress models that came out of McGill, literally about 80-odd years ago, when we started looking at stress and distress, and these original homeostasis models, this is where a lot of this began. And we're looking to chronic stress, the fight or flight principle, all of these concepts that engage so many different systems, whether it's the glucocorticoid system, the whole adrenal system, the autonomic systems. And those were designed for short-term acute problems. But in modern life, all too often, it's chronic acute problems. We're always feeling stressed, and our bodies were never designed for that. Major depression, again, as an example, isn't a single issue of just feeling sad. It's feeling not just depressed and blue, a loss of apathy, a loss of interest, and along with a whole host of biological and psychological changes that we experience. And finally, what can be done about this, and what are we doing to try to address it? Well, many of you have read about the triple aim that the Institute of Medicine was focused on almost 20 years ago now. Better outcomes for our patients, lowering the cost, and improving the patient's experience, right? We've all heard about this. Well, there is a fourth aim that subsequently evolved and is at least as important, and it's the enabling aim that allows any of the other three to happen. And that's the improving ability for clinicians to maintain their ability to stay on top of their game, or of our game. So this includes different domains, general well-being, and addressing the issues through education and skills building of how to stay on the top of your game and avoid burnout. When there are issues and concerns, how do we address crisis? How do we manage it? How do we prevent it? How do we change the culture to be supportive of the fact that, gee, who knew? We're human beings. We have the same problems and the same risks that everyone else does that we try to cure for. And how do we continue to get better at doing all of this? Well, as an educational institution, we have some formal responsibilities. For graduate medical education, ACGME requires accredited programs to educate our faculty, residents, fellows in identifying symptoms of burnout, depression, and substance abuse. This includes informing them of the means to assist those who experience those conditions. The responsibility includes educating residents and fellows and faculty in how to recognize those symptoms in themselves and how to seek appropriate care. And at the med school, LCME has similar requirements for faculty in the med school, it's all of us anyway, and for our undergraduate learners as well. Here in Carillion, we have reinvigorated a faculty vitality well-being committee. And I would encourage the committee members to be as creative as other committees like TEACH, to come up with a snappy acronym, because frankly, Faculty Vitality and Professional Wellbeing Committee does not trip lightly off the tongue. That said, it's really doing some great work. So the committee has been around now for about a year and a half. It's jointly sponsored by the Dean of the School of Medicine and by Patrice Weiss here as the Chief Medical Officer. And it includes representation from our clinical departments, the School of Medicine's Office of Faculty Affairs, the Departments of Basic Science and Interprofessionalism, the Carillion Clinic ACP Council, House staff leadership is represented, Carillion Wellness is represented, and certainly the Salem VA is represented in this entire this process. And this is a years-long process. How do we build this out to change the culture? Because even if we have all of the resources available, if people feel that they're going to be stigmatized, they're not going to make use of it. So we really have to keep working through initiatives like this and many, many others at changing the culture and the perception. For our med students, this year for the first time, since we're now an official college at Virginia Tech, Cook Counseling has dedicated a full-time counselor on this campus, and she is in the building of the School of Medicine on our campus. She is now busy, full-time. She's booked, taking care of our med students and grad students. So this is something that is relatively new, and it's been important, and that's already beginning to help support some of the beginnings of culture change. There are much broader resources. The trust team was something that was developed years ago, Many people from Carillion, including Dr. Greenewald and Dr. Weiss, have helped to champion this nationally as a model for others, where we can address the issues of the second victim. Our patient suffers, we suffer. We're there for our patient. Who's there for us? And so the trust team is a group, including representatives from the Employee Assistance Program and other clinicians who can come together in support of those individuals and the team who provided care. And so it's really important that we feel comfortable making more and more calls to the trust team for them to support us when we're going through difficult challenges. The Employee Assistance Program is a wonderful component. It is freely available to everybody at Carillion, every employee, for at least 3 sessions. You got a problem? Whatever you want it to be. Whether it's a problem at home, a problem with a supervisor, a problem with a colleague, a problem that you're not quite sure how to put your finger on, but you're not feeling good. Call them up, talk to them. You can get in quickly. And if further care is needed, it can be ratcheted up from there in collaboration with you. It's completely confidential. Their records are not part of EPIC. It's very, very separate, very confidential. We have Schwartz rounds. The Schwartz Center has really been involved in helping to support clinicians. It's been around for well over a decade, helping deal with the emotional distress of dealing with difficult patients or difficult outcomes of care. And the Schwartz rounds have really helped us to provide a venue for the treatment team to come together and talk to anyone and everyone who is a clinician at the hospital to come and listen to the distress they experienced as individual caregivers and how they're dealing with it as they provided care to a patient who either was very difficult, there were family issues and the family was arguing with each other, there wasn't clear guidance, and they were struggling with this. So this is a great element that can also provide a more of a case conference approach to support. Mindfulness. The drop-in sessions. Lori Suicidal is a champion of mindfulness who has been involved in and is currently giving courses to med students. And we are able now to, every week, across the street at the rehab, from 12:15 to 12:45, 30-minute drop-in session. Come on over. And so it's the first door on the left, as soon as you go in the main door. And it's a wonderful exposure to just being in the moment and not worrying about what things happened yesterday or what might happen tomorrow. If you haven't experienced it, I highly encourage you to do so. We have lots of lectures through the wellness series. We have a lot of initiatives through Carillion's Wellness Care. There's also a model program that's been developed and is now in use in 30 universities around the country that started at UCSD as an online anonymous screening program. And then if you screen positive, you can have access to call for support, for conversation, and if it's positive and you're willing to then be referred for treatment. And so this is something that can be of real value, and we're looking at this as an additional effort. But I particularly wanted to include this because it's not just our problem. It's everyone's concern. It's everyone's problem around the country. And I think that a lot of the work that we're doing is championing this, but it does require everyone's support, everyone's engagement, everyone's willingness to acknowledge the problem and to work towards helping to resolve it. Now, it seems fitting to close with another quote from the same Dr. Weinstein that we began this with. The more we openly discuss these issues, write about them, and tell people stories, the more people will be able to get high-quality care. We need to support each other. I know firsthand what the depressed brain is like, but no matter what you've gone through, there is a light, and there are so many reasons to appreciate being alive. So with that, in the last few minutes, let me see what questions people have, other comments or other thoughts about these risks. Please.
Do you think a simple vacation would minimize the problem? More time off?
It's a great question. Would encouraging or requiring that people actually take their vacations and use their vacation time, could that make a difference? Short answer is yes. That is one element. We do need to realize that vacations are not just something for the week. There's something for everyone that allow us all to recharge. Thank you. Other questions? Please, Dr. Greenaway.
Yeah, Bob, thank you for this informative talk and for doing it twice. Appreciate that, for trying to make access for people to be able to hear this. My question is about, it gets back to the whole idea of suicide, and you talk about the data that says that many physicians are obviously reluctant to reach out for help. And so I'm wondering what you've learned, either through your own experience or through your research, about ways to remove those barriers for help seeking. One of the things that you and I have talked about and others is that there's a reluctance among physicians to reach out to the present resources that we have, to EAP and things like that, because of perceptions and lots of things. And I'm wondering what you've learned about other ways that organizations have gone about this, like the virtual phone calls and things like that, in order to really make everybody who is feeling that way feel like they actually could make that phone call or whatever.
Well, part of it, in terms of how do we make it easier for people to be engaged in treatment, is initially through a lot of education and making it clear that it's all right to seek care. And in some ways it's a chicken and egg phenomenon, because the more calls we get for care, the more Carillion will invest in the resources needed to deliver the care. And so I think we all acknowledge the need. I think the investment we've made in all of these different initiatives already speaks to that. And I think that we will continue to grow it. And having anonymous, immediate access through online call-in or screening tools may reduce some of the barriers for immediacy of care, because immediacy is important. If you can get care when you're thinking about it right then, as opposed to maybe tomorrow after 8 a.m., I'll try to call to make an appointment. But call right then, right now, making the threshold, the activation threshold, as low as possible. Speaking to any electrophysiologists in the room. Please.
So as we talk about the body, it seems to be in smaller groups than you can really deal with on hospital-wide. Getting Neil's anesthesia people to buy in is a different group than maybe pediatricians or my surgery residents. So the question is what have you observed that's worked within the smaller groups? My own observation is the more the group takes care of and looks out for each other and brings this forward, it's very hard for, we get given all these resources that residents can go and find out if they're depressed, burned out. I can tell you the last person to go do that is the burnt, but their colleague notices it. How do we move forward more within the small groups? You have a different task, I have one, but I'm only looking for things that have been successful for other people in terms of within your smaller group of creating that culture of doing that. Oh,
no, certainly. I think within each small group is the only way, because it's the microenvironment in which changes are actually made. And so within each, whether it's residency program or each section, within the hospital environment, within the ambulatory programs, we need, as we're educating people, as we're having grand rounds, as we're including each new class of learners, we need to have a time period, a seminar, a session on exactly this. And the way that really, not just the education, but the thing that breaks through the barrier is having someone say, I was depressed, I got treated, I'm okay, and you can be too. And you can get treatment and it will not jeopardize your career. And so the degree to which we can reach out, it might be to people who are already retired. It might be to adjunct faculty, if it's not with someone within the department. But the degree to which we can get people who are credible to that group to come in and say, I lived it, and you can overcome this. And so these are the kinds of things. I mean, for example, one of the best examples I know of is Kay Redfield Jamison. Dr. Jamison is a professor at Hopkins. She was the co-author on the nation's standard textbook for bipolar disorder. She is bipolar. She came out. She talked about it nationally and internationally. And so the degree to which people in key positions within the microenvironment are more comfortable sharing their own experiences or bringing in someone who can, that's the way to resolve it.
The other thing I was going to ask, and to follow up on it, a couple of years ago they did the burnout disengagements where they polled both faculty and residents, and my observation was that you could pretty much mirror within each department the residents mirror their faculty. Maybe it was a little less, 5% less, 10%, but it mirrored very directly. It's really easy for me to compel my residents to listen to these, go to these, and I can get buy-in for that. The harder thing is to change my faculty. And my own bias is that in these people, no matter what we do, if the people the majority they follow, if they don't buy in, eventually we lose that.
And that's quite true. And so ideally, in any different department, the chair needs to accept ownership, and each section chief needs to as well. So arguably at a section meeting, to include this every few months, for 5 or 10 minutes, but to reinforce it, to have a grand rounds where someone from that discipline has lived through it. And to really, the more we can make it normal, the easier it's going to be. So we really do need buy-in at different levels. And so I'm happy to participate in any way I can to support different programmatic initiatives. This obviously matters a lot. We've lost people, and we simply can't afford to lose people. We need everyone who is bright enough, motivated enough, and caring enough to go into our profession to be able to provide the care that they can provide until they're ready to retire. So I think we need to stop at this point. Anybody needs to reach out to me anytime. You know where I live. Please feel free to reach out. Thank you so very much.